This documented case will cover double edentulous. We are going to go through the records, the surgery, and a little bit about the conversion. But what we're going to mostly focus on is the pinning process, because the pinning process in a double edentulous is critical to success, and it has some nuances and very unique approaches to setting the fixation bases in the proper position. It is unconventional. As we go through the program, there are check marks that are key points that we will cover and expand upon. So let's start with the records. The records on edentulous, whether it's single or double, are always involving dual scans. All right, so this patient has upper and lower dentures. The dentures do not fit very well. Therefore, doctor performed blue mousse wash impressions, as you can see. This is conventional dentistry. This is basically reline impressions until both dentures are seated to the liking of you and the patient. That material remains in place. Then you add the markers. These are SureMark markers. You can buy them from us or you can purchase them from suremark.com. You will use 6 at least on each arch. So this upper may have 4 on the labial, and then it probably has a couple more on the lingual. All right, so this is one of the scans. Both dentures seated, fitting very well. The teeth are together. That's a CT. That's number 1. And that is seen here on the left. Right? Because acrylic disappears because of the CT and the radiation. So the acrylic disappears, but the markers remain. Then you take a second and a third CT scan with the appliances alone. Right? So this is one CT here, CT2. This is a third CT, CT3. Set the appliance on a piece of foam in your scanner. Double check to make sure that this is in the field of view, the FOV, field of view, as well as the lower. Nothing is cut off. And please inspect your CTs prior to sending. The number one problem with edentulous cases is that the denture is not seated. And what that means is you will see dark areas in your cross sections between the denture and the patient. Right, so you want to watch out for those. And the other main issue is that the prosthesis or the patient was cut off, those two, but primarily dentures not seated. And that just means the wash impression was not performed adequately, or the patient's occlusion was off and now they're tipping. Very, very common. So just watch out for that. So on the left and middle, this is what you will take care of, the CTs. And on the right side, this is what we take care of, where we have used the markers, right? The scan marker fiducials in the CT, and we merge them with the markers on the appliances. And that's how we bring the dentures into the mouth, because the dentures will become the pinning guides. These pinning guides are the patient's dentures. We just modified them to hold on to the fixation bases. All right, so those are the records. Of course, we want the photographs, smiling, exaggerated smile, especially with dentures. We want an exaggerated smile. We want to see where the necks of the teeth are in relation to the upper lip. And we want to do some analysis in 3D because we want to know if and where the bone reduction is. Very, very important, especially when you got a patient that has a high smile line like this. All right, so nice photos. And then left, right, and center retracted. We need to see how these teeth come together. All right, so the records are basically the photos that you see here. These three, and then your 3 CT scans and upload. That's it. Once we have all the records and we put them together, we will get the case ready for the online meeting, plan implants, plan bone reduction if needed, etc. And then we will meet you online, put the case together, ship it to you, and then, of course, create the surgery mats, which help you get through the surgery rather than a big book. All right, this is 6 implants, 5 implants on the upper, 5 on the lower. That's a lot of pages in a implant report coming out of software. So we summarize it for you and put it on a surgery mat for you to tape to the wall, 47 inches wide. And then we also send you the surgery mats that go on the counter for the team to organize all the parts. Implants, MUAs, temp cylinders, organized, grab and go. All right, let's go through the surgery. And as mentioned earlier, the critical part of a double edentulous is the pinning. All right. There are landmarks, but they're all soft tissue. And so that means that the dentures that you originally sent us, the CT scans, those are basically the landmarks, how they fit in the mouth. And there are some options here. Okay, you can seat both pin guides at the same time. And at this point, you can either work on the upper only, where you're seating just the lower pin guide in the mouth and not the fixation base. All right, obviously, both fixation bases are shown here. The reason I'm mentioning the other one first, where there's no fixation base, is because it takes a lot of anesthesia to numb the upper and the lower if you're going to pin like this in the morning. All right, so this is more of option B, to pin everything. Option A would be pin the upper with the lower in the mouth, patient in occlusion, team holding the chin and the head together, just like they're biting with their dentures, and then pin and drill. And we'll talk about flapping in a minute. All right, that's one option. Another option is what you see here, and that is pinning both arches at the same time. Now, this is going to be the most accurate, arguably, but we do have a technique for for double arch where it can be very accurate as well. We'll talk about that. That's option C. So option A, we talked about, take the fixation base off, seat the upper. Option B is numb the patient upper lower, seat both pin guides, seat both fixation bases, pin and drill. Then you can remove the lower pin guide. You can decide if you want to remove the lower fixation base. If you are going to remove the lower fixation base, then don't pin all the way to depth. Leave them a little bit short. That way, when you come back in a couple of hours to do the lower, you can simply push the pins in, hold the pin guide down, and then tap the pins in to full depth. All right, that way you know you still have resistance and fit of the pins. Okay, so that means that if you have both fixation bases in, you have all your sites drilled, you have all your pins in place, you can remove the lower and then address the upper, start surgery. Now, often on double edentulous, there's not much bone reduction. These surgeries should go very quickly, so leaving both fixation bases in is a viable option. Okay, when we get to the lower arch, we'll discuss how to do the surgery where you're going to do all of the pinning for the lower delayed. All right, we'll get to that point. So you'll decide which method you want to take. I think if there's very little bone reduction and anesthesia is going to be viable, especially patients that are edentulous, it's pretty easy to get them numb. They're not perio involved. Could probably do both arches at the same time. Now we're going to get to this part a little bit later. I'll just hint at it right now. When you restore the upper, Like the upper is done, the prosthetic is converted. Do not seat that prosthesis to get the lower pin guide in place. The occlusion is probably going to be different. You can see the poor occlusion on the original dentures. Well, we made beautiful occlusion here, right? When we made these prosthetics. So if you seat this upper prosthesis in a couple of hours and then try to put the pin guide against it, you're going to put this pin guide in the wrong place. And then the prosthesis on the lower is not going to meet these upper teeth. That is very, very important to know that. And we'll cover that a little bit more when we get to the lower, what to do. All right, so now you're going to begin the pinning process. Now, I've pulled in the SurgiMed here, but I just pulled in the upper. But if you were going to pull in both upper and lower, then you would want to have both pin guides instructions on the wall, both SurgiMats. And what you'll notice here, there's a few important things. Extract, obviously there's none, no extractions. Long pins, none, all short pins. All right, so all these pins are short, and here are the cross sections of each pin, A, B, C, D. When it's dentate, there's obviously more vital structures that you can keep an eye on, but this will tell you exactly the pin positioning and the pin length. All right, so that's a helpful little aid that's at a glance on the wall. Okay, now flapping. This is another very important decision to make. What type of flap are you going to perform, if at all? If there is no bone reduction, you may even decide to do a flapless surgery. Now, probably not this situation on the right here. There's clearly got to be some bone reduction here. But if you have no bone reduction, you could do a flapless. All right, that'll be your judgment call. Then where do you make the incision? The most common incision is a crestal incision and a labial buccal flap. And that way the pin guide is resting on the palate and some of the lingual tissue. That's the most common way to do it. Some doctors also make more of a labial flap so that now they have the ridge tissue to support the pin guide. And that may be a decision based on the type of tissue that you're seeing in the patient, whether you have a lot of keratinized tissue or not, whether it's going to stay up or not. So it's really sometimes a game time decision. Sometimes it's more of just the way you decide to do it based on practice. Some doctors also, here you can see, they seat the fixation base around the tissue, and then they lay a labial flap right across the bone reduction line. Perfectly fine too. Now you'll end up with some sutures in the labial and probably a patient who's not too happy with those sutures, but you definitely have a stable pin guide, and you also have a lot of a tissue that you can bring and flap back over around the MUAs. So again, it's philosophy, training, but there are different options. So with both pin guides in, following your diagram here and your instructions on the length, you will pin the maxillary, that's suggested, pin the maxillary arch, and take the pins all the way to depth, tapping them in. Be careful when you tap that you have the patient still in occlusion. You don't want the denture to move, right? Because you don't have teeth holding it in place. So just be careful when you're tapping it in that the denture is not moving at all. Just to go back a little bit, this doctor, Kaushal, he did a normal flap right along the crest. Okay, laid the flap, then came back, of course, and seated the pin guide in the fixation base and did his drilling and pins. All right, so lay the flap and then insert in occlusion with the opposing, and off you go. Okay, there is another helpful indicator here, and you can try this in on the maxillary prior to pinning. You can see the window here, And you can make sure that the denture is perfectly seating, the pin guide is perfectly seating against the tissue, open the patient up, and then you can close the patient down, and you can make sure the dentures are not moving when the patient closes down. So you have a good palatal seat, hold the denture in place, close the patient down, and make sure there's no movement. That's a nice double check before you get started. See the window that we cut out. All right, let's go through the surgery. Now, the surgery part is very typical to a dentate case. Right? The teeth are going to come out. The bone is going to be reduced down to the fixation base. In this case, you just go right to bone reduction if there is any. Obviously, there is quite a bit of bone reduction in this patient. So go through the normal process. And then one thing you can do here is you can look up at the SurgiMat and you can see that we have this cross-section image. And you can make sure that the fixation base is seated as it should be. So here's the image that's on the fixation base. And ultimately, this is a very, very critical step in an edentulous case because the denture obviously could have moved while pinning. It could have moved because of the flap, because of the bone exposure, because of the pressure the patient is under when you're having the patient or holding the chin up. So just have a look at the wall at the SurgiMat and then have a look at the mouth. Do the gaps look close? Right? Then you'll know the pin guide is the fixation base is in the correct or incorrect position. Right. So if it's not, you can make some corrections. Now it's a little tricky because you already have the holes here, right? So if you're only moving this a little bit because you're repinning, the holes are going to be in the same place. So more than likely, in our experience, this is in the proper place. But you can see why it's so critical to follow all those previous steps to make sure the pin guide is secure. All right, so that's a check, and that is for verification that you are seated properly. Then you can also check on the SurgiMat. We show the position of the fixation base facially, so you can see how much bone is to be reduced. Left, right, have a look. Confirm that that's the depth of your fixation base. All right, again, it was sitting on soft tissue. All right, so after making some visuals, you're happy with the position, and then adjust the bone per normal, which is down to the fixation base, apical part of the fixation base. Lots of tools at your disposal. Looks like a Meisinger burr, nice barrel burr, keeps it nice and flat. Reduced down, looks great. All right, you can make another confirmation on the SurgiMat. Right, and then the next step will be the next step, of course, is to seat the carrier guide. I don't have an image of that, but you'll seat the carrier guide, which is that platform that holds onto the prosthesis. Seat it and make sure that it fits passively, that there's no bone holding it up. Maybe the tissue will, just hold it back at bay here. But seat it, make sure that there's no rock, it passively seats. If it does not, there's some bone that needs adjustment. So address that until it seats perfectly and passively. Right, then osteotomies are next. This is the part of the SurgiMat here that gives you implant number, implant size, which drill to use. This is the implant direct kit, so it's a very simple readout of which drill to pull, and all the information is there. Okay, it's just a direct one-to-one which drills to use. Right, now here you can make another visual check that it's seated properly. Right, there's an image on the SurgiMat that shows the osteotomy guide. in place, and you can just do, again, left, right, left, right. Am I in the right place? Now, the beautiful thing about Chrome GuidedSMILE is that you can see the bone. Unlike almost all the plastic guides, you just cannot see the bone. So it's, you have to look down the hole, I suppose, and see if it's in the right position. So do a verification. If it looks like it's lingual, it may not be. Now, maybe, you have to look at how the fixation base is with the bone, but often the angle of the implant and the trajectory of the implant is a little deceiving. So if you think you're lingual, take a tool, one of your drills, and drop it down in and see where it touches the bone. All right, because often an angle site will look like it's not in the right position, and it probably is. It surely is, if everything else is looking correct. All right, so just look at the visual nature of this guide. All right, you can just see everything going on. It's just a beautiful thing. So drill all the sites, and then here's a check, and that is the check here is to make sure that when you are placing your implants, that your depth and rotation are following the top of the sleeve, and then our nubs, right? We have these nubs that are built into the sleeve that manage indexing, rotation. All right, so that means just rotate and stop on a nub with your indicator. Now this is Implant Direct. Every driver is a little bit different, but they're pretty much all based on the nub. And then if you have straights, which this case does, there are no nubs. And then it's up to the doctor. You can leave a dot to the facial. So that way in the future, if you ever have to put an angled abutment in, it angles in the proper way, not left and right mesial distal, but buccal lingual, right? Because you're going to want to move a screw access point to the lingual, not to the mesial or distal, more than likely. All right, so implants are in. Looking good. You can do another verification if you'd like. Make sure everything's in the right place. It just looks perfect. And then there's another image on the SurgiMat for this. You can also check. Now this is a teaching course. This is a lecture on a surgery. As you go through this process, this is not a checklist that you have to follow every time you do a surgery, but we're just teaching you the references that you have in the room, just to verify things are going perfectly. All right, carrier guide is seated. Now this is the carrier guide that you would have used to make sure there's enough bone reduction, right? You'll seat this until it's passive. I alluded to that minutes ago. All right, then you'll place your multi-unit abutments. Now this carrier guide, you see these are straight sites and these are angled. That's why there is this little black mark and a notch back here. The notch is where the implant would come out, the driver, the screw, everything is in the trajectory of the implant. And that way, when you put your multi-unit abutment in, the screw for the angled is at that position. So that gives you guidance when you're putting your multi-unit abutments in, right? The straights, just drop them in, but on the angled, you'll need to know to put your driver through that notch. And then you know your implants and abutments are in the right rotation. And then you can seat the prosthesis and put the patient in a quick bite just to double check everything, make sure you're passive, make sure there's no gaps. If there's any gaps, then it's something holding it up, probably tissue at this point. All right, now a little backwards here, but multi-unit abutments are going in, doctor's torquing them. Here are the notches. So you can't really see them, but well, kind of here, there's a hole. So the screw and the driver and the implant and everything are in this trajectory. All right, so now once you have all the abutments in, then you can look at the SurgiMat and you can see if you have everything aligned. All right, so in this case, you can see this trajectory of the temp cylinder matches the plan. This is a little bit rotated lingual, but not much. This is pretty much looking dead on accurate. All right, so that means the indexing of those posterior implants was done very well. Here's just another visual of what the notch is for. Right, here's the hole for the screw driver. Sorry, kind of going on about this, but this gives you a nice indication of what it looks like, what the carry guide looks like on an angled site. And again, another slide on it, but this will give you a very nice visual. There's the implant, there's the notch, there's the hole on the abutment, down it goes. Okay. Multi-abutments are in, make another visual check. Collar heights, because we use OEM parts, all of the collar heights are chosen during the meeting. And then when you order them, look at this, they are going to meet the software exactly as planned. I mean, exactly. How could you get more perfect than that for a plan? Temp cylinders are placed. You can see sometimes just a couple of degrees of rotation on the angled sites manifests itself in a position that's a little bit off. Ultimately, this works very well, right? Maybe a little bit of adjustment here on the prosthesis. Prosthesis comes out, place the gaskets, seat the prosthesis, add your plugs, backfill, loop the material to backfill to connect the prosthesis to the temp cylinders, and we promote Stellar, which is a dual cure material. Hit this with a light for a minute or so, and then you are solid. And then you can take the blue plugs out, unscrew the screws, take the prosthesis out, insert the take-home prosthesis, right? This is the rapid because it is white on the lingual. So you'll also pick up the take-home prosthesis, and you can do this one first, because then if you have to make adjustments, then your adjustments are minimal on the take-home prosthesis. Now, one thing doctor does is he cuts down his temp cylinders prior to surgery. Now, isn't this nice? Because then when he comes back and fills this up, there's a little bit of a channel for the screw that comes up to the surface of the prosthesis. You don't have metal at the surface, right? Which is very tough to adjust and a little tricky, right? You can nick a tooth, and it also doesn't look very good. So if you cut it short, millimeter two down inside the prosthesis, then it's going to look great. All right, we'll show that prosthesis a little bit later. So let's talk about the lower surgery and the pinning. All right, in this case, doctor decided, just like the upper, to do a crestal incision. Right, and perhaps because there's so little tissue back here, maybe a labial buccal incision might be better. You'll have to decide that. Now, seat the lower pin guide. Now, this is what we were talking about before, where you don't want to have the maxillary prosthesis in already. The occlusion is different. You see? It even looks just like how the dentures did. There's going to be a gap here, and it's closed here because we did such a big reset digitally to get the teeth into place. So this is not going to seat properly. All right, the thing to do is basically this. And what this here is, this is a situation where the doctor, this is not an actual image of it, but I want to give you a visualization. When the upper surgery was done, the doctor removed the prosthesis, removed the rapid appliance, and then with the fixation base still in, seated the pin guide. Right? Now, the pin guide might be held up by multi-unit abutments. Now, those abutments were pretty short. You saw them. You might have to adjust the intaglio of this to get it to seat. But seat this. Then come here, and if you haven't already drilled the holes, Seat the pin guide, seat the fixation base, your flap is laid, pin the lower. Right, now you're in occlusion. Now you're in the occlusion the patient gave you a month ago, 3 weeks ago, and you're pinning the lower. And then when you restore the lower, it will be to the prosthesis that we made against the restored upper. So don't do this. The only time you would ever do anything like this is if we did not make any changes to tooth position from the dentures. And that's uncommon because we usually use patients' existing dentures for the dual scan. All right, well, let's proceed anyway. This will be a little bit out of alignment of the upper, as you'll see. All right, so this means pin, drill and pin, if you haven't already. Drill and pin, right? And this is just kind of reinforcing what we were talking about. That's a new prosthesis on the upper. That's the older denture out of alignment. All right, again, make a visual. Make sure the fixation base is seated properly. And here's the bone reduction level. All right, so you can see that on the wall. You can make sure that that pin guide has been seated perfectly. Then perform your bone reduction. We'll kind of go through this a little bit quicker because it's basically repeat of the upper. And let's just presume this fixation base is in the right place because of your visual confirmation. All right, here you are. You have the SurgiMat to give you guidance on drilling. Make a vertical. Now see, this is where we're talking about earlier, where you might have a sleeve that looks like it's lingual, but the trajectory is coming back into the bone. All right, so don't be fooled by that hovering lingually, but aiming back to the bone. All right, you'll be able to see it on the wall that you're right, and you'll be able to place an instrument inside of your sleeve to make sure it's in the right position. As you can see here, the implants ended in the right place. And all the rest of them as planned. Looking good. All right, just some more visuals. Again, you can look at the carrier guide on the wall and then place your multi-unit abutments. All right, now these were all straight, right? There's no notches. So this part goes very quickly. Place all the MUAs. Seat the prosthesis, make sure everything's sitting flush. I didn't mention again, I didn't show you again, but use the carrier guide to make sure the bone has been reduced enough. You know, you do that all the way back here. Seat the carrier guide. All right. So now the prosthesis is seated. Add all your temp cylinders. You can make a visual here that they're all in the right spot. See how they're angled? They were planned angled. Looks good. Actually, looks perfect. Right, perfect positioning. Place your gaskets. He already cut down the temp cylinders. Right, and then just simply backfill to connect the temp cylinders to the prosthesis. And you can see here, this is where the resin is going to be around the blue plug as opposed to around the temp cylinder. And it really makes the prosthesis clean up nicely and present nicely. And it's easier to adjust and clean up to seat. All right, we know what that is. And then just some little finishing points. Prosthetics are removed, and you will fill in these voids here where the carrier guide supports were, and then you'll just simply adjust and backfill. You can see a little bit of metal here, but no metal around these other sites, not much, and you can fill that up a little bit even more if you want to by leaving the plug in and coming around it outside the mouth and filling that up if needed. All right, looking good. And then delivered. And this is where you can see this is where the discrepancy came in because of the pin guides. and just seat both pin guides when you head towards the lower, and you will be in good shape. A magnificent surgery. Thank you, Dr. Koshesh, for your brilliant photos, and thank you everyone for watching.